All right. I am driving back home from work, working on New Year's Day today. On today's commute, I wanted to just talk about insomnia, the treatment of insomnia, potential differential diagnosis for insomnia. This is something that comes up a lot, both on the inpatient and outpatient settings. The mood disorders like bipolar disorder, major depressive disorder, post-traumatic stress disorder, a lot of our psychiatric conditions have as a core symptom or component some kind of a sleep disturbance, whether that's nightmares and PTSD or insomnia or hypersomnia in the mood disorders. So I think the research suggests there's a bidirectional relationship between the sleep disorders and the underlying primary psychiatric condition, meaning that sleep disturbance can lead to or increase the probability of having a mood disturbance or mood disorder, and mood disorders can contribute to the sleep disturbance. And there might be some sort of feedback loops on that. So, oftentimes, what will have happen is just taking the outpatient setting as an example. Someone might have a mood disorder, you treat them with something, and that seems to get better, but they're still having the isolated symptom of insomnia, having a really hard time falling asleep. Oftentimes, we'll use trazodone to start. Now, trazodone being a sedating antidepressant might be a reasonable choice for someone with unipolar depression. I think the evidence for it contributing to mania is pretty low because I think that's the case for the sedating antidepressants in general. So mirtazapine, trazodone, those antidepressants. If you are kind of on the borderline, you're not really sure if you're dealing with bipolar disorder or major depressive disorder, then those would probably be on the safer side, especially when there's comorbid insomnia. So we like to use trazodone first off for insomnia because it's relatively safe. It's not addictive. That's not a controlled substance. And one thing is that the research suggests that it doesn't disturb sleep architecture like some of the other sleep aids do. Now, trazodone is not FDA indicated for insomnia. It's off-label, but the research suggests that it maintains, at least to a large extent, the normal sleep patterns, the normal sleep stages that we should go through at night, on REM sleep and REM sleep, and the normal dance that we have through those stages at night. Whereas things like the Z drugs, zolpidem, azopiclone, those kinds of drugs can disturb or change the sleep architecture, as it's called. And all else being equal, it seems like if something is able to give you normal sleep patterns when measured through EEG, polysomnography tests, that would be preferable. Of course, and you don't have the same tolerance buildup with trazodone that you often see with the Z drugs or the benzodiazepines. So trazodone, and this is interesting because I've seen in some textbooks, some academic textbooks that trazodone really should not be used for insomnia because it's not FDA indicated and there's no good randomized clinical trial data. And I think that's where evidence-based medicine can maybe go a little too far. I mean, trazodone is one of the most prescribed substances. I think the clinical anecdotal data that it works is pretty overwhelming. So it's curious to me that the textbooks that are trying to be the most evidence-based will go as far as saying you shouldn't use it and you should instead use the FDA indicated drugs like the Z drugs because we have randomized clinical trial data. I have no doubt in my mind that trazodone is an effective medication and safe. I haven't had any adverse events with trazodone. You have to be careful with orthostatic hypotension, and there's the risk of priapism. But usually we're using pretty small doses for sleep, somewhere in the range of 25 to maybe up to 100 milligrams for sleep, as opposed to when it's used for as an antidepressant, you're going to be using dosages more in the 200 to 400 milligram range would be the more antidepressant territory. So for someone that has really bad insomnia and you're dealing with, unipolar depression, trazodone is a perfectly reasonable antidepressant. And I would still dose it all at night, even though the half-life would suggest you should dose it twice a day. Because most of our psychiatric medications are not working through immediate fast mechanisms, right? Like a benzodiazepine, a short-acting benzodiazepine, you need to dose it several times per day because its mechanism is, immediate GABAergic tone increase. However, antidepressants don't work immediately, right? That's the whole reason why we have to wait several weeks for them to really take effect. And so they're doing something at a slower time scale that probably doesn't warrant consistently high plasma levels like you need with something that's working immediately or on a shorter time scale. So trazodone, yeah, I think trazodone is great. I think we give up on trazodone too soon. We might try 50 milligrams and the person says, oh, it's not working. Maybe we'll push it to 100 and then, they're still like, oh, I still can't sleep with it. But if they're tolerating it well, I would keep pushing it. Keep going up by 25 to 50 milligrams every couple of days. I've had quite a few patients where it's not working until all of a sudden it works great at 200 or 300 milligrams. Now, at that point, you're definitely into antidepressant territory. But again, unless you have really high suspicions that this is going to increase the risk of mania or you're worried about some drug interaction or something like that, there's not really a big deal with them being in the antidepressant territory, even if you're just using it for sleep and depression isn't the main issue. So I've had some good success just pushing it up to 200 or 300 milligrams with select folks. Obviously, sleep hygiene is important to talk to your patients about. I think the most high yield things being having a consistent wake up time, because it's hard to control when you feel tired at night, but it's easy to control when your alarm wakes you up. And so you need to build up sleep pressure. And sleep pressure, biologically speaking, is primarily a function of adenosine buildup in the brain. So adenosine is a byproduct of just normal cellular metabolism in the brain. ATP, the main energy molecule in all of our cells, gets metabolized to ADP and then eventually adenosine in the brain. And so we have these adenosine receptors in our brain that basically tell everything to kind of shut down. So caffeine is an adenosine receptor antagonist, and that's how it basically blocks that sleep pressure from taking effect. And that, half-life of caffeine is about 6 hours or so for many people. And so I often give my patients an outpatient setting like a 2-week or 30-day challenge. If there's someone who uses caffeine, and oftentimes they'll say, oh, caffeine, I don't think it's really, the problem there. But I think we really do underestimate the effects of caffeine and other stimulants like that. And so I often challenge my patients to go at least 2 weeks with 0 milligrams of caffeine and see how their sleep does. Because again, that is a primary mechanism for triggering sleep, is that adenosine buildup working on the adenosine receptors. And so if you're blocking that, it's going to have some effect. Now, of course, you do have adaptations over time, but still, I think I've seen, and also just anecdotally, like if I quit drinking caffeine for at least 2 weeks, my sleep is way better, even if I get to the point of being able to drink quite a bit of it every day and still being able to fall asleep because I built up a tolerance. Like my sleep is still a lot better if I drink 0 milligrams of caffeine. I suspect the effect might be more pronounced in older age, just as the blood-brain barrier becomes less robust. And this is in the speculation territory. I've seen that people become more sensitive to caffeine with age. And I don't know, my guess might be that that's something to do with blood-brain barrier integrity. So yeah, eliminate caffeine as a trial. Try to have a consistent wake-up time, even on the weekends. Try to use your bed only for sleep so that your brain associates the bed with going to sleep. Avoiding blue light in particular in the evenings. People can buy blue light blocking glasses online for just a couple of bucks. You can turn on the, blue light filter so that your screens are more reddish in hue on your computer and your phone. Exercise is really important. Again, adenosine is a product of of brain metabolism. So you want to try to build up a lot of adenosine so that, it kind of forces you to go to sleep. I'm sure everybody's had those days where they're running around really busy, and by the end of the day, like as much as you'd like to binge on Netflix or something because it's a Friday night, you just can't. And, no matter how much caffeine you've had, like you just have to crash because you've just built up so much sleep pressure. You got so much adenosine, there's nothing you can do about it. So exercise, especially earlier in the day, so that your heart rate has a chance to go back to baseline before bed, because high heart rate before bed it, disturbs sleep, is really important. I think there's decent research suggesting that there's a dose response to the number of steps you take. So I try to advise patients to get at least 7 or 8 thousand steps a day to help with their sleep. The definition of sedentary lifestyle is less than 5,000 steps, and having tracked my steps a lot, being in an office job when I was working outpatient, yeah, it was hard to get above 5,000 steps unless you're intentionally doing some sort of exercise. Now that I'm working inpatient and running around the hospital all day, I'm getting typically around 7 or 8 thousand steps a day. And I think my sleep has definitely improved just anecdotally as a result. So you've got your other sleep options, right? When do you turn to the Z drugs or the benzos? I go to those if trazodone hasn't worked. Benadryl, diphenhydramine is a reasonable option for short-term issues, but because of the anticholinergic effects, not something you want people to be on all the time. If it's here and there a few times a month, maybe that's fine. I'll use diphenhydramine personally for the occasional sleep issue. Melatonin's an option. Keep in mind, melatonin is a natural hormone released by the brain, and typically it starts to be produced about 2 hours before your normal sleep time. And so I advise my patients to take melatonin 2 hours before they want to go to sleep. So if you want to go to sleep around 10, try to take your melatonin around 8 p.m. In terms of dosing melatonin, I think people are way overdosing melatonin. I see people starting off with like 6 milligrams. Now the brain is releasing like nanograms of melatonin, and we're talking about taking 6 or 10 milligrams of melatonin as a starting people off. I think that's way too much. Of course, there's a bioavailability issue, like how much of the 6 milligrams that you orally ingest is going to end up in your brain. I don't know, but I think there's decent research to suggest doses as little as 1 milligram are still effective. So I usually recommend starting people on the lowest effective dose. I mean, that's how it should be for every medication, right? Or any treatment. Use the lowest effective dose. So I would start with 1 milligram 2 hours before bedtime. If you're getting a little signal but not enough, then maybe you consider going up to 2 or 3 or whatever. I had a patient who was taking like 100 milligrams of melatonin, and she was getting like altered mental status. I can't prove that it was caused by the melatonin, but there wasn't a whole lot of better explanations out there. That's an N of 1. I don't think there's any research to suggest that, but yeah, you should ask your patients who are taking melatonin how much they're taking, how much they take at max. Because sometimes a lot of patients think more is always better, and they could be taking just absurd doses of melatonin, and that can cause some issues. There's been some recent research that came out suggesting that chronic melatonin use is associated with all-cause mortality and a specific cardiovascular disease. I believe that research is observational. And of course they try to make adjustments for confounders, but you can't adjust for every possible confounder. So observational research always has to be taken with a grain of salt. But again, the brain releases like nanograms of melatonin. So using exogenous melatonin that's 10 times higher than what the brain releases over years, I wouldn't be surprised if it's doing something negative over time. Yeah, for my really, really intractable insomnia patients, I have found astazolam, which is a benzodiazepine drug, to be helpful. And again, obviously, there's the risk. You got to know your patients and do a risk-benefit analysis and all that stuff. But when sleep is really bad, astazolam could be a good option. It's dosed 1 to 2 milligrams at bedtime. And just anecdotally, I mean, I haven't had any of my patients misuse it or become really dependent on it, but it's been effective. You got to watch out for things like respiratory disorders, because of course the benzodiazepines are also somewhat of a muscle relaxer. So if you got really bad sleep apnea or something like that, and your airway is gonna potentially collapse more. That could be dangerous. And I'm just like driving home, so I'm just coming up with this stuff off the top of my head. I just getting off work, haven't prepared anything, so there's a lot to say about insomnia. I think as someone who has personally dealt with insomnia and doesn't have a primary psychiatric disorder other than the sleep issues, it can be really bad. So I think taking your patients seriously when they have sleep complaints, because it can be very scary to not be able to sleep. Having personally dealt with that. Let me see. Oh, the dual orexin antagonists like brand name Belsomra, Dayvigo, so suvorexant and lemborexant. I I've used those quite a bit. I haven't been very impressed with them so far. I've had a few patients where it's been really effective for them, so definitely worth considering. But I've also had a higher than expected rate of adverse events. I've had a patient that had altered mental status. Now, he had a lot of other medical problems going on, but it seems to be something that can cause some cognitive issues in susceptible individuals. So, yeah, I'd kind of watch out for that one, but definitely worth trying. Gabapentin, you could try high dose gabapentin, 900, 1200 milligrams. Of course, you wouldn't start there, but creeping your way up from maybe 300 at that time and 600 to 900, and especially if someone's got comorbid alcohol use disorder or anxiety or diabetic neuropathy or something like that, some other reason to use gabapentin, that's a possibility there. I don't use any psychotics. Some people use like Seroquel or something like that for insomnia. I might go there for super intractable insomnia, especially if there's a comorbid mood disorder, since quetiapine could be helpful for depression augmentation and things like that. But with the metabolic side effects and all that stuff, I wouldn't go there until you've tried lots of other stuff. Or if they've got a comorbid mood disorder, then that could make sense from the get-go. Sometimes hydroxyzine can help if there's like if the problem with sleep is anxiety related. Yeah, I think you gotta try to pin down what might be the contributors to their poor sleep. So do sort of a lifestyle inventory. Try to figure out some of the factors. Is it because of anxiety? Is it because of nightmares? Is it because of too much caffeine or other possible stimulants? What other supplements are they taking? Do they just have poor sleep habits? Sometimes you just ask and it's like, well, I'm just playing video games all night. And so they just got really bad sleep hygiene, and that can require a little bit of CBT to kind of get through that. Also consider medical causes, sleep apnea, ask if they snore, ask if other people have seen them snore, if they have witnessed apneic episodes, if they look like someone who possibly might have sleep apnea, very overweight, thick neck, all that stuff. If there's substance use, are they drinking alcohol? Because once the alcohol might help them get to sleep, but then they metabolize it and then their brain bounces back in sort of like a mini withdrawal state. Acid reflux is another one. So when people lay down flat and they've got weak lower esophageal sphincter tone, then acid starts gurgling up and it can give them weird feelings. And they may not fully recognize it as heartburn, but it can disturb their sleep. There's also because it can kind of irritate the vagus nerve and give people palpitations or weird feelings like that. That can contribute to insomnia. Do they have heart failure or something else like that that could be a factor when they're laying down flat? How many pillows do they have to feel comfortable using to fall asleep? And of course, mania should be on the differential. In terms of supplements for anxiety-related insomnia, magnesium supplements can be essentially helpful. Valerian root can be sometimes helpful. Just to sort of recap, I'd say for run-of-the-mill insomnia, the highest yield things for me would be a 14 to 30-day caffeine, 0 milligrams of caffeine challenge. Wake up consistently every day, get at least 7,000 or 8,000 steps a day to build up that sleep pressure, that adenosine. If you're going to medications, definitely start with trazodone if there's no contraindications for that. And don't be afraid to push it up to 300 milligrams. Well, I will leave it there. If anybody has any other specific questions about insomnia, please do leave a comment. You can leave a comment on like the Substack, BrandonBrownMD.com. So definitely open to other episode ideas. I feel like I want to record these episodes when I get off work. It's like so busy at my job that sometimes I'm like, I don't even know what to talk about, even though I've got plenty to talk about if I were to sit down and think about it, but just don't have time to sit down and think about it. So it would be easier if someone just gave me some questions and then I could, just sort of think out loud on the topic and record it. So, all right, hopefully that was helpful. Happy New Year.